Hi, Dr. Saito. Welcome to GI2. Thank you very much for coming from so long away from Japan. Hi, Mangione.
My great pleasure.
Thank you.
Okay.
Fausto, can you hear me, Fausto?
Yes, yes, we can hear you very well and see you very well too. So we have the panelists and the speakers here that I just introduced. You know who they are. Please go ahead. The word is yours.
Okay, thank you, Fausto. First of all, I'd like to thank you and Abside and organizing committee this kind of invitation for me, for my team to participate in live transmission in this important meeting. Thank you very much for all of you. I'd like also to introduce my team. I have Dr. Salvador Cristóvão by my side, because, before giving the word to Dr. Saito. We have our nurses, operators, Euclides and Silvia, that are working with us. Flavia is our anesthesiologist. Dr. Julio Marchini is going to present to you and to the audience the clinical data of the patients. So before giving the word, the comment of the session to Dr. Saito, I'm going to ask you, Dr. Julio Marchini, to present the clinical data of this patient. Please, Dr. Julio.
Thank you so much, Dr. Mangione. So this is a Mr. ABS. He's a 38-year-old male. He has hyperlipidemia. He has a BMI of 30, and he was previously asymptomatic until December 2011 when he had an episode of angina at rest. So currently he is a stable angina, class 2, in the use of nitrates and beta blockers. Other medications are aspirin and rosuvastatin. His physical exam is normal. He's alert and well. He has a blood pressure of 130/90 and a heart rate of 61. He has regular heart sounds with no murmurs, and his lungs were clear on auscultation. His labs from today, he has a creatinine of 1 and a fasting glucose of 90. This is his resting EKG, which is a normal sinus rhythm, and he has some T-wave inversions and a ST segment, unspecific ST segment depression, changes in the inferior leads. He had a stress test performed, and this was his maximal effort on the Elistad protocol. And you can observe in the lateral leads, V4, V5, and V6, especially in V5, he has a 3.5 Y-point depression ST type. And he had typical chest pain at maximal effort. So he was referred. This is from a previous diagnostic cath, and you can see he has mostly normal wall motion, except for some mild hypokinesia in the apical anterior segment. His Euroscore, logistic Euroscore, is 0.88%, and based on this previous diagnostic cath, he has a syntax score of 25.5. Thank you so much.
Thank you, Dr. Julio. I'd like also to say that it's a privilege, it's a pleasure to receive Dr. Saito. Dr. Saito doesn't need any kind of introduction. He has a lot of experience treating the CTO's lesions. And now I'm going to ask Dr. Saito to show. This is important to emphasize, to say that this is a very difficult case. We choose a very difficult case for Dr. Saito, but it's learned a lot out of this case. I learned a lot of the experience of Dr. Saito. So the word is yours, Dr. Saito, to show the angel of this patient.
Okay, please look.
Okay, to run the image?
Yeah. Okay, you can see the angiography.
Can you see, Fausto, the angel of this patient? Okay.
Okay. Today we had double catheter insertion from the both groins. You know, these are 7 French introducer, and for the left coronary, I took EBU 3.5, And for the right coronary, I took the right judoking with side hole, and this is a simultaneous angiography. You know, because previous diagnostic angiography was not clear for image, so we took this morning, and this was that one. And as you can see, the LAD is totally occluded, and the length of the occlusion is almost 10 centimeters. And also, the right coronary is totally occluded. And, you know, the length of occlusion is, again, 10 centimeters, you know. So this is a quite difficult case. And so honestly speaking, this is a young patient, and double vessel, important vessel occlusions. So and also the distal anatomy is not bad. So I want to send this patient to the surgery.
It's a good candidate.
Yeah, good candidate for the bypass surgery. But anyway, this patient was arranged in this session. So anyway, I want to ask your strategy from the panel.
Do you want to discuss with the panelists, Fausto, before?
Yes, so I think the first question to ask is which
we have done some work here with the sign for the satellites.
Gilberto Nunes, which vessel would you start first?
Well, I guess the first question,
that is the first question.
Tackle this patient or shouldn't be, because this is a mild symptomatic patient. We don't have the extent of ischemia that this patient has. This is clearly a very complex percutaneous intervention to be done. It's a very long occlusion in the right, and also in the LAD. We don't know when this happened, so how old those occlusions are. So it's really tough to see. I would probably begin with the right coronary, probably, because you can see better the distal part of the right coronary. But I think this is a very challenging case. I think that surgery should be also thought of to start with. So this is going to be a very long procedure, a lot of contrast. So I think this should be discussed beforehand with the patients, all the possibilities that we have for treatment, clinical surgery or percutaneous. So that's my view.
Yeah, no, I agree. I mean, but you are here for the session of the intervention, so obviously this patient has good arguments to go to surgery. I'd like to hear from Marco, which vessel would you do first? Because I think you have to remember, if you open one vessel, it's only one vessel total occlusion. So, you may be lucky and you'll be able to open one of those very quickly, and then it's becoming only one vessel total occlusion, not two vessels total occlusion. So what are the features that tells you which one to start with?
I think I probably would try to open the LAD first. And the reason is not a totally anatomical reason. I'm not totally convinced by anatomy which one we should open. They are both long CTOs, and one is receiving collaterals from the other. So, but the reason is more like in Gilberto's side. I think if we are going to embark in this procedure percutaneously, and I think I wouldn't do it. I would try to open the LAD. If I'm not successful, I stop the case and I would send the patient to surgery. So the only reason, and if I'm successful in opening the LAD, okay, then you can continue in the same day. It depends on how long it was the procedure, or the next day. But I would first try to open the LAD, just because of clinical reasons, not anatomical reasons.
Yeah. Fausto, do you see any features that suggest that one vessel would be easier than the other?
No, I think both of them will be really hard to open. I probably would start with by the right. If I get success, and I maybe try to go to the left system. So it's, and also, if you can maybe open the right, you can get some, if you're not success in the LAD, try to retrograde approach to the right.
Okay, so maybe we'll just do it with the raise of hands for the panelists. How many would you start with the right? Raise your hands. 1, 2, 3. And how many LAD? 1, 2, 3, 4. So it's about even. Anyone from the audience say, how many of you will send this patient to surgery? Raise your hands. Yeah, I think that at least third. How many of you would do the right first? How many would do the LAD first? Okay, so the majority going to do the LAD. I would probably also to take the LAD first on the same premise that Marcos said. If you're not successful in the LAD, you should stop, and you should send him to surgery. If you are successful in the LAD, then it's becoming a total occlusion of the right. But I don't see any features here that tells me that the right would be easier than the LAD. That's why. Okay, Dr. Saito, what have you been done so far? I saw some wire somewhere there. Saito-sensei? Yeah, we lost him for right now.
Ron, I have a question. I think that maybe in this case, one helpful tool to have beforehand, before embarking on this procedure, is to have a tomography of the coronaries, just to get a sense of where the right coronary goes and where the LAD goes. So I think this is a very useful tool for this kind of
very good point.
Very complex anatomy.
Saito-sensei?
Yes.
Which vessel you started?
No?
We hear you now. Yeah.
I started from LAD because for the right coronary artery, I cannot identify where is the entry point. So and also the lesion length is very long. So I started from LAD. Okay, please. And I took fine cross microcatheter and started with field XT. But the entry plaque was so hard. And then I quickly switched to Miracle 3. However, I cannot go in. And then started to change it to the Confianza Pro. But again, it's impossible. So I thought that this occlusion might be very, very difficult. And also, I could find some, septal connection from proximal LAD to the distal right. So I quickly moved to the retrograde approach for the right coronary artery. Okay. And this is Corsair. Yes, please. No.
Okay. To run the image?
Yes. This is a tip
Trying
injection.
the retrograde approach from a septal?
Yes. We can see some connection between the septal and distal right. Okay, go. Next.
So at this point, you're going to bend the LAD and you're going to try to open the right in the retrograde approach, correct?
Yes. And we can see some very acute bend at the distal point of the septal branch. So it was quite difficult to cross the wire through it. And first I started from Sion, from Asahi, that is a wire.